Okay, great. So, welcome to this next installment of the Learn and Lunch webinar series on aging. We want to welcome you all and thank you for joining us today. We have an excellent presentation by Dr. Pang, who I'll introduce momentarily. Today's topic is on depression and aging. And just a little background for this presentation about the format. We will have time at the end for questions, and Dr. Pang will be able to answer any questions you have. So please maybe just make a note of your question and we can circle back at the very end. Also, this session is being recorded. We plan to archive that on the VA website, which is called jerryscholars.org. And I do have the website at one of the final slides, so you will see that written out, and you can go to that later. Let's see. With that, I would like to introduce Dr. Andrea Sherman to provide a little more background about this webinar series. Dr. Sherman.
Hello, everyone, and I'm sorry that I can't see you today. One of my cameras has decided not to work today, so apologies, but greetings to everyone. I'm a curriculum consultant with this project, and welcome everyone, and we're delighted to have you participate today. And the Consortium of New York Geriatric Education Centers is a partnership with several facilities that bring education and training throughout New York State. We're housed at the Bronx VA GREC, and Mount Sinai Medical Center is the umbrella from which we provide education and training with partners like Mount Sinai, the Bronx VA, Columbia University, New York University, and many community organizations. So this is the third in a series of Learn and Lunch webinars. We need to have the Learn first and the Lunch second. And we provide trainings that address really core competencies in aging that you as healthcare practitioners really can use to have cutting-edge information. We also give specialized trainings in key topic areas, and we're happy to meet your specific needs in terms of addressing what you might have interest in. And Jake will fill you in on the next webinar, which comes as a specific request from you. So I know we have people from different places on the line, so let's just have a really quick, brief check-in here. From the New York tribes, who do we have here? Do we have anyone from Oneida? Anyone from any New York tribes? I think you have to unmute your phone to introduce yourself here. We do see who you are, Barbara Nephew. I'm not sure. Are you from St. Regis? We had St. Regis respondees, so I'll assume we're going to have St. Regis people on the line. And then I wanted to specifically welcome Dr. Judy Howe, who's the director of this program, Dr. Josie Kramer, who runs many Jerry Scholar programs throughout the nation, and also particularly to Wendy Stoddart. Wendy, do you just want to say a brief hello to everyone?
Hello. I'm glad to be a part of this.
And to just let everyone know who you are, so we'll have you as our reference point, too.
Okay, I'm the director of the New York State American Indian Health Program. So I work with many of the nations in New York State who have tribal health clinics. And New York State provides some contracts to support the operation of those clinics, along with some of the nations reach out to the Indian Health Service for funding.
Great. Thank you and welcome. And with that, I'm going to turn it back to Jake, and we'll roll out the program. Thank you.
Okay. Thank you, Dr. Sherman. So at this point, I would like to introduce our speaker for today, who's Dr. Linda Pang. Dr. Pang attended Penn State University. She graduated from medical school at Jefferson Medical College and completed her internal medicine residency at Boston Medical Center, where she also completed her work as a hospitalist. Currently a medicine and palliative care at Mount Sinai Hospital. Her research interests include evaluating effectiveness of the social work care coordination model with accountable care organizations. She has a particular interest in geriatrics and palliative care health education in community settings. So with that, I'll turn it over to you, and you should have control of the slides right now.
Okay, great. Thank you so much, Jake. Thank you so much for the introduction. And hello to everyone. I'm really delighted to be here. Can you hear me? I know I think Jake was cutting off a little bit, but I just wanted to make sure if everyone can hear me right now.
Hi, this is Judy Howe. I hear you clear as a bell.
Okay, great, great. Thank you so much. So hopefully, I really hope that we have a good session today with this webinar. I'm glad you took the time out to hopefully get away and learn a little bit more. What I'm going to do right now is turn off the webcam just because I think I'm a little unused to this right now and I just don't want too much of my motion here bothering everyone else. And we can definitely move forward. So, sorry, So our learning objectives today, like Jake said, that I'm really going to focus on geriatric depression. I hope at the end of this presentation you will be able to describe the assessment of late life depression and also recognize the treatment modalities that can oftentimes be offered and used in late life depression. What I'd really like to start with is a little bit more of a background on depression in the elderly population. And then I'd like to go into a case presentation of a patient. And with that case presentation, I'd really like to also review the evaluation and treatment plans that can be offered. So I wanted to begin with what I thought could be like a general basic definition for what depression is. Depression is a mental health condition in which feelings of low mood interfere with daily life for weeks or longer. I think people can oftentimes experience sadness, but also they can have other emotions like irritability or feel angry. I think what I do want us to be aware of is that depression is not a normal consequence of aging. Sadness and grief, those are normal responses to life events that occur with aging. I think we oftentimes see that we have patients, they feel sad when they have a loss of independence, like when they move from their home to a retirement.
I'm here.
Hello. Whether or not that may be like an assisted living or a nursing facility. I think oftentimes people feel bereavement when they have a close friend, family, their spouse.
Can I hang up?
Hello, sorry.
Can I just, this is Judy Howe, ask everybody to please mute their phones? Thanks.
Thank you, Dr. Howe. And so like I was saying, so I think there are certain times when people can feel sad during different states in their life. But really, despite these losses, what normal, healthy, independent, community-dwelling elderly in the U.S., they overall have a lower prevalence rate of clinical depression than the general adult population. So I think that's what we should really take away, that if we see someone who is depressed, this is someone that we should reach out and help. And why is it really important for us to reach out and help and recognize when people have clinical depression? It's really important, especially for our elderly patients, because it leads to disability, cognitive impairment, and exacerbation of medical problems. There's been a study that depression in late life is an independent risk factor for heart failure among elderly women. There's another study that shows that having depression increases your risk for just a mobility disability in 6 years by 73%. So I think that number seems really high for me. And also it leads to increased use of healthcare services and also costs because of that. And there's actually, in the early 1990s, a Minnesota HMO, it showed that older patients greater than the age of 60 in their HMO who had depressive symptoms had a 19% increase in the number of outpatient encounters and a 30% increase in the total outpatient charges at their HMO. And also, depression increases mortality from all causes. A lot of study, I think, has also been dealing with depression and patients with cardiovascular disease. And it's seen in an older study that these patients, after following an MI, a myocardial infarction, were more likely to die in the first 4 months after the event, with a rate of 26% versus 7%. So I think almost, almost close to 4 times as much. I wanted to give you guys a little bit more in terms of numbers and just how common we do see it. I think the prevalence of depression, it really depends on the definition that I will get into a little bit later, and really depends on the venue. So I think across all comers, for the community, when they did a survey, it really shows that in terms of elderly men and women, around 1 to 2% interviewed met the diagnostic criteria for major depressive disorder. Like I said, that will get into the definition a little bit later. In terms of the primary care setting, major depressive disorder has been identified in 6 to 10% of the patients, elderly patients. And the prevalence of minor depression is much higher, from 8 to greater than 40%. The other two numbers really just goes to show that patients who are in long-term care facilities, nursing homes, do report a higher prevalence of depression, and similar to the inpatient setting too. So as you can see, it really, the numbers are up there. This is just another chart that I wanted to show. I think unlike younger persons with depression that you may also be seeing in your clinic, I think elderly persons with depression usually have other medical comorbidities. And so major depression is more common in the medically ill in patients who are older than 70. And as you can see down here, this is a prevalence for the community elderly. Hospitalized and geriatric inpatients are in the 30%. And patients with cancer, stroke, MI, and Parkinson's disease, they all have prevalence of much higher. Similarly, there's also been studies showing patients with dementia, the prevalence ranges from 20 to 40%. And that's for Alzheimer's dementia. Patients with COPD can also have prevalence rates of 20 to 30%. So now that we kind of get a sense of how prevalent depression is in the community, I really wanted to define it with the DSM-5 criteria and go through it. I think the good news of that, even though the DSM-5 criteria recently came out in 2013, the diagnosis for major depressive disorder has not changed from the DSM-4 criteria. So what we've learned from years ago, this is still the diagnosis. What it includes is that 5 or more of the following symptoms must be present nearly every day for a 2-week period. So the time period is part of the diagnosis. You have to have at least one of these core symptoms, being depressed moods most of the day or anhedonia. And then you have to have a couple of these additional symptoms, which include weight loss, appetite change, insomnia or hypersomnia, sleep difficulties, motor changes, fatigue or loss of energy, feelings of worthlessness or guilt, ability to think or concentrate, and thoughts of death or suicide. I think while the DSM-5 criteria for major depressive disorder has not been changed much, I just wanted to discuss a little bit about some of the other shuffling around of the classifications. I don't want us to go into too much detail. I think that it would be good just for us to have a similar lingo when we talk to our psychiatry colleagues. Otherwise, I think on a whole, I think depression is it's concerning in the elderly population. It really should warrant a close follow-up and strong consideration of treatment, regardless of where we're actually going to put them under. I think, like I said, the major depressive disorder is that definition we have. The only thing that I want to mention is that they took out the bereavement exclusion. The bereavement exclusion in the DSM-4 criteria really said that, oh, well, if someone had a loss, such as the loss of a loved one, they may be sad for up to 2 months, and we'll call that the bereavement, and afterwards maybe they can have depression. And they realized, and I really agree also, it sounds like you can be in bereavement and you can have this for more than 2 months, even up to 1 to 2 years. And now they've also been shown that bereavement precipitates major depressive episodes, and there really is more of a continuum. So there's not a strict time cutoff anymore. I think also to help us kind of understand the difference between bereavement and major depression, though, I just wanted to give us a little bit of the differences here. In bereavement, it's often triggered, like we said, by the loss of a loved one, versus in major depression, it can be triggered or it's just spontaneous and people can just mood. In bereavement, you often see these waves and ups and downs of emotion, that there are times when they think about the loss and get really, really sad. But other times, these patients should actually be in a better mood because they remember the good things. They remember the past and what they really enjoyed with their loved one. Whereas major depression, this low mood that they're feeling, it should be there all the time, almost every day, really, as part of our definition. And in bereavement, people often have preserved self-esteem, whereas in major depression, they have really low self-worth. Just touching a little bit on persistent depressive disorder, this is the criteria that they kind of lump together in terms of dysthymia that was part of the DSM-IV criteria, and also what they've now called chronic major depressive disorder. So it's for people who've been having some of these symptoms, may not hit all of the criteria for major depressive disorder, but have been having these symptoms of depression for at least 2 years. The other one that I want to note is other specified depressive disorder, which includes minor or subsyndromal depression. And the reason that I really want to note that is because oftentimes our elderly patients fall under this category. You know, they may have these symptoms of depression for up to 2 weeks and longer, but they don't hit all of those criteria. And sometimes I think even for me, when I was in training, I'm like, well, if they don't hit it, is there a strong indication? What should I do? But I think really now that I'm learning, it's, even if they don't hit it, that doesn't mean we shouldn't acknowledge it and try to see what we can help and treat with. So I think minor depression in the elderly is very important. So why is it so difficult, I think, in terms of diagnosing depression in seniors? It's oftentimes because our older patients, they don't present with the typical symptoms of depression. They aren't really going to come into our clinic saying that, oh, I feel really depressed or I'm sad. They're more likely to come in preoccupied with a somatic complaint or even cognitive symptoms. I think they're going to come in there. You may think it may be something mundane, that they're saying, I just have persistent back pain, or my constipation is just not getting better, and this may be the presenting symptom of depression. And oftentimes, it's also difficult to tease out if the patient has depression or dementia, especially if they also come in complaining that, or their family is complaining that there's memory loss. And unlike younger patients who have depression, this is not a concern when you think about it, but for us, we really want to help tease it out because I think and oftentimes patients with serious medical illness, they oftentimes do have some coexisting depression, like we said, but they can also be misinterpreted as depression, such as patients with Parkinson's disease. They can come into our clinic. If they have the masked facies, the bradykinesia, and the stooped posture, some people may think that, oh, is that depression, whereas really it's just part of their other disease. And I think oftentimes what is difficult for our clinic, too, when patients come in is, I think there's still a stigma of mental illness, and I think especially with some of our elderly patients, it's difficult for them to accept a diagnosis of a mental illness, and also difficult to talk to them about medications, and sometimes not wanting to take medications because they feel that being in this mood, sometimes they just feel like it's normal. And I think it's really for us to also tell them that this is something that we should help treat because it's not a normal process of aging. So with that, I really want to, knowing that information, that depression is common in the elderly and that it's difficult to diagnose at times, I just wanted to bring our first patient, Ms. E. So she's an 86-year-old female. She has a history of hypothyroidism, back pain, osteoarthritis, hypertension, so a couple of chronic conditions. She comes into your clinic. She's accompanied by her daughter who says that, you know, I've noticed mom is more fatigued, she's having more memory problems, and she doesn't want to eat at all. What should I do? Is there anything that we can do to help her? You learn a little bit more about Ms. E, and you learn that she is a retired secretary. She's recently widowed. And she's also considering that maybe she needs to move into an assisted living facility because her back pain is really limiting her mobility, and she's just like, I maybe want something a little bit with a little bit more care. So you also get a little bit of her psychiatric history, and she has no history of depression that you know of. She's never been in an inpatient psychiatric facility. So knowing that, I think I oftentimes need to remind myself that a lot of times our elderly patients, they have atypical presentations of typical illnesses, and oftentimes the symptoms overlap for a lot of conditions. So when a patient like Ms. E presents to my clinic, what I'd really like to consider is this due to some of her medications? Can medications cause some of those symptoms? Can it be due to medical conditions that she's already having? Is it dementia because of this memory loss that we're talking about? Or is this really depression? And I think oftentimes when people come in and my concern is of depression, these are the other conditions I'm really thinking about and trying to rule out or see if there's any overlap. So I think that goes to my first question. In terms of which of the following medications can cause depression, if we think that it's A, propranolol, B, ranitidine, C, lorazepam, or D, prednisone. And I think instead of maybe a causality, we can also think about like which of the medications can have some symptoms or have some effects that are similar to some symptoms and effects of depression. So taking a look at this chart, actually, basically the answer was all of them, and this chart is a lot. And I think what I want us to note is that there's a lot of medications that we may or may not be prescribing our elderly patients that could be causing some of those symptoms of depression. And I think I probably should have titled this Medications Implicated in Depression. And I think the other part that I really want to point out are the risks of polypharmacy, which I think is a very key topic when we think of elderly patients also, not just in depression, that oftentimes polypharmacy can muddle your diagnosis for depression, but it's also a risk factor for geriatric syndromes. And I know you were already talking a little bit about geriatric syndromes with Dr. Bookbar in one of the earlier presentations. So all the more reason, I think, for us to go over, make sure we do a good medication reconciliation, the patient's medications, see if there's a strong indication of needing it or not, and really taking off medications that they may have just gotten on because of hospitalizations and because of other providers, and so on. I just wanted to talk a little bit. So the beta blockers, there's evidence that kind of goes either or of whether or not they truly cause depression or whether they cause some of the fatigue symptoms. And I'm not saying that if patients have an indication like they have heart failure and they absolutely need to be on a beta blocker and they also have some symptoms of fatigue or concern of depression to take it off. Like, that's definitely not what I'm saying. But I think for sometimes if we see patients, if they have a beta blocker on for hypertension and you are concerned about some of their symptoms and you think that this may or may not be depression, this is something that you can consider. Should you change it and see if taking off that medication is helpful for the patient? In terms of the steroids act in the hypothalamic pituitary adrenal axis. What it really does is lower the serotonin levels in the body, and knowing that that's kind of what causes depression and other psychiatric disorders. The benzodiazepines like lorazepam that I had put in as one of the possibilities, as we all know, it's a CNS depressant, and it really is that type of effect. That's what I would call like a hangover effect, can manifest itself as depression. Ranitidine is still on here, and truthfully, when I looked at it, also on Micromedics, it was like a less than 0.2% of possible causing depression. So, you know, this is not a medication that I would say, I'm concerned someone's depressed, I would definitely take off. But also, this is not a medication I think patients need to be on lifelong unless they have a strong indication for it also. So when I see Ms. E in clinic, I think I also would want to get some basic lab tests just to make sure that this may not be causing some symptoms, and I think these tests would be simple on the first visit. I would get a complete blood count. I think I wanted to make sure she doesn't have anemia, and a general blood chemistry screen. Oftentimes, I think patients who have electrolyte disturbances, especially in terms of calcium, can present with some CNS symptoms. Otherwise, I also would like to know this in case of some medications that we may be starting. I think low vitamins like B12 and folate would be important to check because this is something also that may be easy to replete. And both hyper and hypothyroidism can cause symptoms of depression. So checking a TSH would be, I think, a good thing to do. And along with that, even though this isn't a blood test, what I think it's important just to do a cognitive screening because, like we said, it's not one or the other in terms of direction, but it kind of helps us assess the patient a little bit more. And so with that, I actually wanted to talk a little bit about dementia versus depression, because I think oftentimes we do see patients who come in who have family members who bring them in, and their question really is, I think mom is forgetting things. We don't know what to do. I think what are we going to look up? I think dementia is a really scary thing to think about, and I think the presentation can be often very similar. This table shows basically some of the differences and similarities between dementia and depression. What I actually want to focus on is going down the list in terms of cognitive impairment. Patients who present with dementia, their cognitive impairment is not really going to change. Whereas patients who present with depression, it can be inconsistent a lot. If you wanted to do a cognitive screening test like an MMSE, you do it once versus the other. The patients with depression can have what you'd be concerned for moderate dementia once, and the next time they come back and it could be normal, mild cognitive impairment. So I think understanding that is important. I think in terms of the disabilities, I do see this in our patients too, that in dementia, the disabilities, they oftentimes conceal it. I'll have patients who have difficulty walking, and I want them to walk with a cane, and they're just like, no, I think I'm fine. I'm just going to try to walk all over the place. Whereas patients with depression, when they come in, they notify you a lot more. They're just like, I can't walk. I don't want to walk. I don't want to get out of bed because of my back pain, because of my leg problems. What are we doing here? In terms of memory impairment, this is often something that I think would be easy for us to kind of take a look too, because in terms of patients with depression, they complain of the memory impairment versus patients in dementia. This is not what bothers them. This is what bothers their family members, and the family members are concerned. But for them, this is not a big deal. And then in terms of the answers to the questions, I think oftentimes when we do tests like the MMSE or just a clock draw to take a look of whether or not patients have dementia, the patients with dementia will try, and they will. I'll ask them, oh, can you draw a clock? Can you put the numbers? Can you put the numbers in the clock, and can you put the hand and the minutes at a certain place? They'll try to draw a circle. They will try to put the numbers, and sometimes they may not be in the right quadrants, and they'll draw to the best of their ability and hand it to us. Whereas patients in depression, depending on how mild, moderate, or severe it is, they'll try, and then they'll say, I just can't do it. I just can't, and just stop doing anything that they do. And half the time they're almost there, and you see that there is a circle, that they have the numbers in the right quadrants, but they just don't want to finish. And even with any coaxing, they're just like, I don't want to. Why are you doing this for me? I'm really frustrated by you right now. I don't want to do any of this. So I think this may be sometimes helpful in terms of teasing out just in the clinic when you see the patients of whether or not this is dementia versus depression. So the risk factors for depression are a lot, and I just want us to briefly go over it a little bit because I think it's just important when you are evaluating to get a sense of if they have these risk factors, am I more concerned that depression is higher on my list of what I think they have. So the risk factors for depression include being female, the female sex, social isolation, being divorced or single, lower socioeconomic status, comorbid general medical conditions, uncontrolled pain, insomnia, functional impairment, and cognitive impairment. And like I said, the cognitive impairment is it's a two-way street. I think depression can be a risk factor for cognitive impairment, and cognitive impairment can be a risk factor for depression too. So knowing all of this and going back to Miss E, we'll take a look at our medications. She is on levothyroxine 75 mics daily. She's on Tylenol extra strength every 6 hours as needed. She says that her back pain is still there. She doesn't want to take her oxycodone because one time she took it and she got knocked out, and she'd rather be in pain than take that. The Tylenol is not entirely healthy, though. She's on amlodipine, 10 milligrams every day. In terms of some of the labs that we checked, her TSH was normal. Her B12 was not concerning for B12 deficiency, and all her other basic labs were normal. Just in terms of a cognitive screen, depending on what, I guess, which values you want to say, this would be either normal or just mild cognitive impairment for her. And then taking a look at her risk factors, because we think that there's really nothing else in terms of her medications, her medical illness, and I don't really think that she has dementia. What are her risk factors when I'm evaluating depression? She's female. We said she was widowed, so she's single now. And it sounds like her back pain is really limiting her. And I think maybe even more of risk factors. Is she a little bit more socially isolated because she can't get out because of this back pain and because of what she feels like is a functional disability of hers? And I think this is what would be going on and thinking in my mind. So if you're concerned of depression in terms of the elderly versus the younger, I think the first thing you would do is screening. I think there's a lot of valid and reliable measurements to screen in the older adults. I've only listed a couple that I think our clinic uses a little bit more often. The USPSTF, like you probably know, it recommends a 2-item screen because it's simple, it's easy to do, it's a yes-no answer, it has really high sensitivity. It's like greater than 90% in terms of screening for depression. The specificity is really low, and that's why you really need to follow up after that. And I think the other positive part of screening with the 2-item screen is that it really encapsulates the core symptoms of the diagnosis for major depressive disorder. So these are the 2 questions the USPSTF recommends. And it would say, in the past 2 weeks, have you often been bothered by feeling down, depressed, or hopeless? Or in the past 2 weeks, have you often been bothered by having little interest or pleasure in doing things? I think the ease of the screening, we actually have our medical assistants when patients come in and they're getting their blood pressure and getting their other vitals checked. Our medical assistants are part of what helps us with the screening, and this is something really simple, and I think shows how easy it is. And oftentimes what happens is, if you screen positive, we'd like to follow up with either the PHQ-9, which includes the DSM-5 criteria for major depression, so it's a helpful tool also for diagnosis, or the geriatric depression scale. I want to touch base a little on the geriatric depression scale because it's the most commonly used and the most validated in the older population. Its benefits is that this is a self-report instrument, so you can give it to the patients, and it's actually been studied in multiple settings for the geriatric population. It's been in the community and primary care and inpatient, outpatient nursing home settings. I think it also has been studied a little bit in patients who may have some mild dementia, and these questions, it feels like, aren't easy enough for kind of helping them answer because it's a yes-no format compared to some of the others, and I'll try to show you the PHQ-9 too. The other benefit of the geriatric depression scale is that it's free of a lot of these somatic complaints or the sleep complaints. And that's beneficial for the older population is oftentimes people, the elderly patients of ours, if they have other medical they can complain of that a lot too. So it really takes that out for us. The last scale I do want to mention is the Cornell scale for depression and dementia. And basically, as the name suggests, it's a really good scale for people who are demented because what it does is it incorporates information given by caregivers to help you kind of diagnose whether or not patients have depression. So this is what I just want to show you a couple of questions in the next 2 slides of what you see when you give someone a geriatric depression scale. It was originally developed as a 30-item instrument, and then people were like, this is too time-consuming. It's a little bit too difficult. I'm in an outpatient primary care setting sometimes, and I don't know if we have the time and the ability to do this. So it actually, because of that, it was shortened to a 15-item short version, and these 15 questions were chosen because of their high correlation with depressive symptoms in prior validation studies. And it's a good form. And actually, you can complete it in 5 to 7 minutes. It's really ideal for patients, especially if they're easily fatigued or they're limited in their ability to concentrate for longer periods of time. And what you would do is you give it to them and ask them to circle yes, no. And what you see are that there's some of the answers with no are bolded and some of the answers with yes are bolded. And the answers in bold are the ones that indicate depression. And here are the last 15 answers also. So when you get this, and the numbers that you're really trying to look for is if you get anything with bold, more than 5 bold answers circled, you should be concerned about depression, and you really should do a further evaluation of that patient. If you have more than 10 bolded answers circled, it's almost always indicative of depression. Some of the ones that I highlighted in yellow, actually don't, no, back, I apologize. So going back, I have highlighted 5 questions in yellow because it looks like there's also been some studies showing that an even shorter version of the geriatric depression scale has been shown to be helpful in trying to screen whether or not patients have depression. In our clinic, I think we use the 15-item version more, and I actually have not used the 5-item version, so I think it's difficult for me to get a sense. It looks like from the studies, at least, the validation studies, that it is pretty sensitive in helping patients, in helping clinicians detect for depression. I also just want to show you the PHQ-9 because we do use this a lot in our clinic, and we use it with another one of our models that I'm going to discuss later. What I think the pros of using this scale is that oftentimes people can detect how severe a patient's depression is, and a lot of times, and this scale has been validated more often to show the change over time. So sometimes some of the therapists help us in clinic in detecting after someone starts an antidepressant, a month later, what is their PHQ-9 again. I think the cons of this is that it has a lot of somatic complaints that, like we said, if we think that it's related to a medical illness, you really shouldn't score it. But I think it makes it a little bit difficult. And I think just from a personal experience, when I do try some of this, I do both. I think I'm leaning a little bit more towards the geriatric depression scale, but when I do the PHQ-9, I think it's easy for patients when they definitely don't have the symptom or they have it nearly every day. But when they have it some of the days, they just get caught up a lot on the numbers, and they're just like, well, should I, do we think it's this? I don't know. Is it 2 days? So I think it really does trip them up a little bit, and I think it makes it a little bit difficult for some of my patients. So I think going back to Ms. E, her PHQ-2 or her 2-question screen is positive, so I'm concerned. And like I said, I think after even evaluating some of her other conditions, I don't think it's related to that. Her geriatric depression scale is 10, and like I said, that makes us concerned for depression. Her PHQ-9 is 11. And I think after talking to her a little bit more, I think this is definitely something that I'm concerned that she has major depression. And moving forward from that, I want to ask, what would you recommend to Ms. E? Do you oftentimes use in your clinic psychotherapy? Do you use pharmacotherapy? Or do you like to use other alternative modalities or even anything else? So actually, the first thing I did want to talk about was the effect of exercise on depression, because I think I really like it. I really wanted to prescribe a little bit more. So there is actual evidence that exercise interventions, ongoing physical activity can improve depression in older adults. This is just one systematic review that was done, I think, in 2012, and there's been others in other journals taking a look. I think the reason I pulled this one out that I like is because they have randomized control trials, and it's really showing that a lot of different types of training, Tai Chi, Qigong, as well as endurance and strength training, all of them really, at least as what you can see here, is really favoring in terms of the exercise. In terms of these trainings, what happens is that it's really not just, oh, let me send you to physical rehab and they see what they can do. These are sessions that people have to go to, whether or not it is in their home or somewhere else, but it's 3 to 5 sessions a week, 30 to 45 minutes each for a total of 3 to 4 months. And I think that aerobic exercise is often prescribed for treatment for mild to moderate depression, and I think the only thing is just getting a sense of if you think your older patient is capable to increase their level of physical activity. For Ms. E, I think the question would be, does she think that her back pain is going to limit her so much that she can't participate in the exercises? And I think like I said, there's other reviews out there, and some of them do feel that the more exercise they do and the longer they do really has a trend for higher remission rates in the higher dose exercise groups. I also wanted to touch base a little bit on psychotherapy. I think sometimes I do hear that, patients, when we have geriatric patients, we don't prescribe them psychotherapy because they either think that, oh, this doesn't work, or we should just give them medications because their depression is so severe. But it's actually shown that psychotherapy is really useful and really helpful for our geriatric population too. I just listed, so some of you out there may actually know this so much more than I do. I just listed the top 3 that's been shown to be most effective for the geriatric population: cognitive behavioral therapy, problem solving, and interpersonal therapy. And as you probably know or heard of it a little bit, cognitive behavioral therapy, you really just combine techniques of the cognitive part of cognitive therapy, which is helping patients recognize dysfunctional cognitions, modify their negative thoughts, and really uncouple behaviors from negative thoughts. And I think the behavioral part, some of the behavioral activation that you may not even need like a therapy license to do, which I think is something that we can even do in clinic ourselves, behavioral activation. You really just want to help increase the frequency of pleasant activities that patients have. And I think even without me understanding, without like the going for psychotherapy in and of itself, I think telling your patients and trying to get a sense. I had one patient who felt that really she was so depressed, but her grandchildren were what brought her joy in life. And we try to work out a way that I think her son, who was also in the city, was nice enough to also be involved in her and his mom's care, and worked out a way that he could bring the grandchildren around a little bit more. And I think I'm glad that that really helped her a lot more than some of the medications that we were giving. The standardized psychotherapeutic approach, oftentimes, just going back to a little bit of basics, it's weekly visits over a period of 8 to 12 weeks. So, I think either psychotherapy or pharmacotherapy can be first line, or you can do both together. It's really going to be up to you and your discussion with your patient of which one they feel most comfortable with and which one that they're willing to try and undertake. I think sometimes the psychotherapy portion, for me and my patients that we are limited, is that it's really difficult for them to come into clinic to participate in group therapy sometimes, and that may be a limiting factor. Other times it may be that they really don't want to take medications and they'd rather try psychotherapy. And I think just working with them is really important. So in terms of pharmacotherapy, once again, I listed, I think, some of the more common medications that we start prescribing elderly patients. Out of these 3, is there one that you feel more confident in prescribing, that you feel like, I know how to prescribe this medication, the SSRIs, SNRIs, or tricyclics? I think when I think about that elderly patient in terms of prescription, it really is trying to find something that has the lowest risk of side effects, or side effects that I'm willing to tolerate in this patient. This list, I think, has a lot of medications on board. I did split it up by some of the classes, the SSRIs, SNRIs, and the TCAs. I think what I would like to say is that citalopram and sertraline is oftentimes found to be safest in older adults because it has a good adverse event profile. It's a low cost, and oftentimes we use it as first line. The advantages of this medications are that it's non-sedating. Citalopram does have this concern of QTC, and the difference between the younger population and then the older population is that you can go up to a max of 40 milligrams for citalopram in the younger population, but the concern of QTC is already is much greater, so we would only go up to 20 milligrams in the older population. We try not to use fluoxetine and paroxetine too much, but I think these are SSRIs to still consider. The reason for fluoxetine is because of the longer half-life. Oftentimes, if there are drug-drug interactions, you really don't want that to stay in your system too long. And naproxetine, it's really because of the anticholinergic effects that, as you probably already know, that's really a no-no in terms of medication and their effects for the elderly population. Oops, sorry. Other medications that are safer for patients are some of the atypicals and the SNRIs. I think that in terms of the SNRIs, the venlafaxine is one that I often see prescribed for patients too, and I think the benefit of the SNRIs, like you see in terms of the potential advantages, is when patients have concomitant pain and you think that it's neuropathic pain and you may want something to help control it, this is a medication that may be able to help give them some pain relief and also be a part of their depression. And it also goes back to the talk that we're saying about polypharmacy. If you have one medication that can help both things, maybe we should do that one medication instead of multiple ones. In terms of the atypical antidepressants, mirtazapine, oh, I'm so sorry. Sorry, you guys. Mirtazapine or Remeron is oftentimes used, as well as bupropion. As you can see, the side effects of mirtazapine is sedation and weight gain, but people can use these side effects sometimes for potential advantages. Mirtazapine, both in my training hospital and here at Mount Sinai, oftentimes I see it used a lot in the hospital for patients who have insomnia, because you're willing to tolerate that side effect of sedation. This is what you want from it. And also for elderly patients who have who feel that they're really not eating too much and we really want to help stimulate their appetite. At lower doses, it already gives you some of these potential advantages, and you can definitely increase the dose to help with also the depression in patients too. In terms of bupropion, I do see it oftentimes prescribed a lot for patients with Parkinson's disease, because you really don't want to, some of the other ones may interact with patients with Parkinson's disease, and the dopaminergic properties of this one is good. The only thing that you do want to watch out for is because of this kind of potential advantage of activating for patients, it can worsen into a little bit of agitation. So this is something that you really just have to figure out, which risk are you willing to tolerate. For patients who have seizures, I definitely think this is not going to be a safe drug to prescribe. Trazodone is another medication that I see prescribed every once in a while, not at antidepressant doses sometimes, but at lower doses to help with insomnia. But if you have a patient who is both depressed and has major insomnia symptoms, this is one medication that you can think about. I brought up the TCAs because I think this is an older class of medications that you can also consider, definitely not as first line. Nortriptyline is useful both for insomnia and also for neuropathy and for pain control. But I think the side effects of the sedation, the anticholinergic side effects, the risk of falls, and at most the cardiac arrhythmias are just so much risk that I think in terms of all these medications, if there are safer alternatives, we really don't prescribe as much. And I think the other thing that you probably already know, and just to be aware of, is that the overdose risk of TCAs is so much higher than these others that if your patient that you think is so depressed that you're really concerned of suicide, is definitely not something that you should prescribe for them. And so you take a look at the medications, you talk with Ms. E. Out of all of them, out of all of them, you decide to start citalopram 10 milligrams every day. You tell her that you're going to continue following with her, you're going to give her a phone call in a week and see how she does, but when should you expect to actually see improvement in her? So is it 1 to 2 weeks, 4 to 6 weeks, 8 to 12, or 12 to 16? And I think what's important to note here is that, yes, medications typically take 4 to 6 weeks for the young adult population. This is what we say. We'll try to give you medications, make sure that in a week that you're not having too much of side effects, and really up you and see how you do in 4 weeks. But I think in the elderly patients, you may not see a full antidepressant response until 8 to 12 or even 16 weeks. That being said, however, there has been a study of at least around 500 geriatric patients that said that, by 4 weeks, if you have absolutely no response while you're already on an adequate dose of antidepressant medication for these patients, you really should consider switching. So Miss E comes back. Her citalopram, she didn't have any side effects, so we increased her citalopram to 20 milligrams. She comes back and she's like, I don't feel anything. I feel like I'm still just as depressed as ever. Don't really think that anything's doing better. So seeing her, what would you suggest next? Would you increase her citalopram? Would you add any agents or switch any agents? And I think going down one by one, we wouldn't increase her citalopram to 30. Like we said, the doses above 20 are associated with prolonged QT and the risk of arrhythmia, and it's really not within guidelines for geriatric patients. To go above 20. So I wouldn't do this. I wouldn't add bupropion, which is another antidepressant that's oftentimes used for augmentation because she's had no response to the citalopram, so we're really not augmenting anything. I wouldn't switch to buspirone. Buspirone is another medication in a couple of trials that's shown that you can use it as an augmentation agent. Buspirone, if you use it by yourself, is oftentimes more prescribed for generalized anxiety disorders, so I wouldn't switch for this as just a single agent. I wouldn't add olanzapine. Olanzapine is sometimes used as another additional agent if you feel like your patients have psychotic depression, and that is common in terms of the elderly, but she didn't really have any of those symptoms, so we're not going to add that. And I would basically switch her to sertraline. Like I said, this is another SSRI that's oftentimes safe in our adult, or older adult population. I think switching within the same class of medications is still appropriate. You don't have to say, well, one SSRI didn't work. That means none of the SSRIs are going to work, and we're really going to try to switch to another class. That's not the case, and we can definitely still switch her to sertraline. So what is the course of late-life depression? It's not great. I think just understanding that late-life depression is a recurring disorder. These are just two. I'm sorry, I'm just taking a look at the time also. These are two studies that basically show that remission is not as high as we would think. Only in a 6-year follow-up, this is a longitudinal study in the Netherlands, 23% of patients had remission. 44% had this up and down and not really that great of a course in and of itself. And 33% of patients were chronic. In terms of a 3-year follow-up, so this was basically it was difficult to tell if people were on antidepressants or not on. It was just looking at a prospective study. This was a 3-year follow-up of looking at patients who are either taking nothing, taking medications, or having both medications and psychotherapy, and really how many people had recurrence of depression again. I think, and as you can tell, the numbers are really high for placebo, but I mean, I think there's still quite a number that recurred on medications too. And oftentimes we say, like, only 50% of patients respond to their first antidepressant, so this is something that you're going to have to continue working with. The other point that I wanted to point out in terms of late-life depression is that maintenance is oftentimes longer than for patients who are a little bit younger. I think the concern is that we do think that they have more higher chances of recurring, and that this comes with such a lot of medical comorbidities and illnesses that we think that really, I think it's a risk-benefit ratio, and it's, some of the guidelines do say that we should probably keep our older population on an antidepressant longer, even after one single episode too. I wanted to bring up electroconvulsive therapy because I know that sometimes this sounds like a scary thing. This is something that I would definitely not prescribe in the primary care clinic, but I do see it prescribed in the psychiatric centers, and it's oftentimes useful for our geriatric population. It's really effective for patients who are severely depressed. And really, it's actually even first line for patients that we think are at high risk for suicide or major depression that's life-threatening or really impairs their functioning. The response rate is usually 70%. And I think the concerns are always the cognitive side effects that really limit the acceptance by a lot of people in the community. I think the acute postictal confusion is around 30 minutes, and really that goes away. In terms of the other side effects, the anterograde amnesia also usually goes away, and it's really the retrograde amnesia that we do see some lingering in terms of the effects. And there's really actually not a huge contraindication for the elderly patients. It really is for patients who have like increased intracranial pressure, or if you have unstable angina, those would be like serious contraindications for ECT. The other model that I really want to bring up is this collaborative care model. So in the past 20 years, there's been a substantial body of evidence that having a collaborative care model to help treat depression is really important. And IMPACT is one of the models. I just wanted to, so there's a couple of other geriatric depression models that are out there. I really appreciate IMPACT. We oftentimes use this in our clinic too. And it really, I think, helps because instead of having what's usual care is oftentimes the primary care provider and the patient, this has additional, I think an additional support system also for the primary care. And it really just shows that putting all those people, really, what you're really trying to help prevent is make sure people are not lost to follow-up. Make sure that we're following, following some type of structure of how we're going to be assessing these patients, how we're going to be treating those patients, what we're going to be offering these patients in terms of either psychotherapy or pharmacotherapy and helping them out. Besides the primary care doctor, there's a depression care manager who can be either a nurse, a social worker, or a psychologist. They educate the patients on depression. They help with the close follow-up so no one falls through the cracks, and just helps in other things such as behavioral activation, pleasant event scheduling, can also help with counseling. And there's a psychiatrist, I think that's a point person, that if you're having difficulties, this is the person to help you ask. And I also just want to go a little bit towards the results. This was the first study, and then afterwards, from the University of Washington, they've actually done a lot of different studies and had a lot of different positive results. But out of the first study, they've shown that with this model of collaborative care and making sure that it really is a community that's helping the patients and not really one by one, there's been a more than 50% reduction in depressive symptoms, 45% in the patients who were part of this collaborative care model. The patients who've been in this model are more satisfied with their depression care, and they really had lower functional impairment and depression severity and greater quality of life in terms of some of their scores. So I think then, so as you probably can tell, I really, really enjoy the collaborative care model. I did want to also shift gears a little bit and talk about suicide, because I think that's important for a geriatric population. So my question is, out of all suicides, what percentage is completed by the older adults? Do we think that, it's low, absolutely nil? A little bit out there, 16% or 45%? And so basically the answer is 16%. So older adults make up only 12% of the U.S. population, but they account, depending on year, up to 16 to 18% of all suicide deaths, which I think is really important because it really isn't that it's no longer an issue for us as our patients age. They have fewer attempts at suicide, but they're more likely to die with their suicide attempt. And the reason, as I'm going to show in the next slide, is because they more likely to use firearms as a means of suicide. So this is taken from the CDC data in 2013, and it's really just age-adjusted death rate for suicide per 100,000 in population in each age range. And as you can see, yes, the death rate for middle age is the highest in the terms of this bar graph, but the second highest is actually patients who are 85 and greater. And the other thing that I do want you to see is the orange up here is suicide by firearm, and the purple down here is suicide by other means. And as you get older, you are almost, at least almost like 2.5 times in the 85, in the age 85 or greater, 2.5 times more to have to commit suicide by firearms. So I think especially in patients, if we're concerned about suicide, asking about if there's a firearm in the house is really important too. Okay, good. I'm fine. So I think in summary, I just wanted to talk with everyone. Thanks so much for listening to the presentation again, that late life depression is common. Oftentimes it is difficult to diagnose because patients have coexisting medical illnesses, cognitive dysfunction, both or even all, but it's really important for us to help tease this out. I think screening for depression is important, and assessing it with a scale, much like the geriatric depression scale, would be useful and helpful in clinic. And oftentimes, if you think that patients have depression, things to consider would be prescribing exercise and making sure that prescribing psychotherapy or medications to treat depression is available and in your arsenal. I also think that if possible within your clinic, a consideration of an implementation of the collaborative care model would also be a really good thing to consider. And like we said, medications, SSRIs are really the first-line medication for our older population. And these are my resources. So, Jake, hopefully it wasn't too over.
Thanks, Dr. Peng. Thank you for an excellent presentation. Yeah, we're just over, so I think we have a couple of slides left to wrap up the presentation. And while we are over, for anyone who's able to stay on a minute or two longer, maybe let's take one question. And if anyone has a question, you can go ahead and ask it now.
I had a question about what do I do if I'm working with an older adult and they've just received a difficult diagnosis and they're depressed about it. What do you recommend?
I think that's a really good question, because I think that may be something that I didn't entirely touch upon. I think oftentimes we do see older adults with this because, like we said, there's a lot of life-changing events, or they may have diagnosis of difficult medical comorbidities. I think what's important that even if we think that patients may not fit under these umbrella categories of major depressive disorder or any of these disorders, I think it's important to make sure that we listen and acknowledge. So acknowledging where they're at, I think, is important. Listening to the patients and making sure that they understand that you won't abandon them. I think oftentimes there's this concern of abandonment from some of the primary care facilities, and making sure that you continue following up with them, because I think what you really want to help out with also is that they don't tumble down and get into worse things such as a major depressive disorder. And I think even if people don't fit these categories, there's no reason why you can't offer them treatment and support. And whether or not it's anything just referring them to a support group or anything within the community that's available out there would be important too.
Thank you.
Great, thank you, Dr. Peng. And I'm gonna, if we have more questions, feel free to please email those to me, and I can forward those to Dr. Peng, and we can get the answered for you in that manner. At this point, I just want to alert everyone to this page, which is our registration page. We have a SurveyMonkey survey set up so that if you did participate today, you could please go to the survey and let us know who you are and where you're from. And that helps us tremendously with our required reporting to HRSA, which funds this program. So thank you for please taking the time to do that registration. Thank you again all for attending today. I wanted to also let you know that our next topic will take place, our next webinar will take place on June 2nd at the same time, 12 to 1 p.m. Eastern. That's going to be on gambling and addictive behaviors, which actually came as a request from the St. Regis Mohawk Clinics team a couple of events ago. And so we look forward to that, that webinar, and I will be sending a calendar request so that you'll know when that's coming. Thanks again to everyone, and thank you again to Dr. Peng for a really great presentation.
Thank you, Jake, and thank you, everyone, too.
Bye-bye, everyone.
Okay, thank you. Goodbye.